Okay, so the first patient is a 74-year-old female. This is her pleura effusion specimen. So we see a lot of inflammatory cells, and they were very tiny, like small cluster of cells. So the nucleus looks in a median size comparing to the adjacent cells, but you can see this is a very tight cluster with a glandular feature and also shows some luminal border. So if you take a look of the requisition sheets, she actually had a past history of pancreatic cancer. So the morphology is compatible with pancreatobiliary feature, and it is very easy that we will see more well differentiated type of nucleus. So this looks relatively bland looking comparing to the usual pulmonary adenocarcinoma that we most commonly see. But the feature is that it's all usually will form this very tight three-dimensional cluster with a very obvious luminal border. And the cytoplasm also show quite like abundant cytoplasm. Some might also show a little bit mucin material. So this is very typical for the morphology, cytomorphology of a pancreatobiliary origin adenocarcinoma. So we have a couple of these clusters. And because the primary is in the pancreas, so it's already across the diaphragm to the pleura cavity. But this is also a very obvious like cluster of metastatic cells. So this is positive for adenocarcinoma and also compatible with the pancreatobiliary tract origin. So this is from the same patient. So she had two different specimens. This is from the same patient. So you can see this is also a very typical. And you have more nuclear atypia and polymorphism over here. So if we take a look of the cell block preparation, yeah, and it is also easy for us to identify very similar cluster of metastatic tumor cells. So the next specimen is kind of similar, except that the patient doesn't have a confirmed history. So this is the ascites specimen coming from a 51-year-old female. So she came to our emergency room department, and the clinician sent only two specimens, each with 2 millimeter liquid fluid of the ascites. That's it. They suspect there's a pancreatic cancer. So just by morphology, I think in this specimen, we only have this one cluster of cell. So this looks very similar to the prior specimen. I think we can call these positive or suspicious because the patient doesn't have any like a proven biopsy. This is her very first specimen, and they only give us 2 millimeter specimen, and we only see one cluster of cells. So we call these suspicious. But the morphology is very similar. In this specimen, it even show a little bit more nuclear atypia. So again, this is her second specimen. Also, this very tight cluster forming this tubular structure. The cell is slightly enlarged. The chromatin pattern is actually quite like a homogeneous, quite uniform. We only see very, very small nucleolus over here, and that's it. So we call these suspicious. I think this is positive, but yeah, they can go ahead to do a biopsy or something like that. So back to our most common specimen, one of our most common specimen. This is from pleura effusion. The patient has lung cancer and has been treated. So these are like very high-grade adenocarcinoma. You see this gigantic nucleus, prominent nucleolus, and vesicular chromatin, and you see glandular arrangements, some a bubble in the cytoplasm, and the tumor burden is really high, like more than 80% of the cells that we see here are cancer cells. So this is very common for primary lung adenocarcinoma. So this is a recurrence disease. This is her cell block, so they can use this cell block to do like a drug-resistant molecular testing. So this is, I think this specimen is very difficult to interpret. A 63-year-old male, a lot of cells. He doesn't have a confirmed primary lesion. So here we see on low power, a lot of inflammatory cells and histiocyte. We start to see a few clusters forming these tight, like cluster of cells. So it looks a little bit indistinguishable from the adjacent these histiocyte-looking cell. I think the major issue is that it is very three-dimensional. And here we do see occasionally some cells show prominent nucleolus. So the three-dimensional is not good. You need to check if there is any issue. So here we see more like a atypia. Here we do see an atypical cell, but it is a necky nucleus. So it looks like the patient has metastatic adenocarcinoma, but due to the preparation, it's a little bit difficult to appreciate the morphology. So when we go to the cell block preparation, it is also not very easy to identify which are the cell cluster that we see in the specimen. Could be these very tiny like cluster of cells. So he is a male patient. The clinician didn't see anything yet. They suspect there is stomach cancer, but he has received like 3 stomach biopsy, but they were all negative, so it's kind of difficult. Yeah, so it's a little bit weird. And so we go ahead to do a MOC31. So you see they were individual cell as well as small cell cluster were strongly positive for MOC31. So I think we can call these metastatic adenocarcinoma. And then we check the prior like a specimen from our hospital. He does have one specimen that we sent out negative. So I was regretted to retrieve the slides. As you can see, this is even more difficult to interpret. So sometimes the preparation is very not optimal. It's not very easy to confirm if there is a tumor or not. So I think at that time, probably on that day, the hematoxylin is very strong. So we do see these very dark staining cells along with a lot of like extracellular, like a proteinaceous material. So it's uncertain if these are the similar cells that we see just now. But yeah, I think some of the cells are indeed histiocytes. So it's very difficult to make distinction. But however, some of the cells do have hyperchromasia, but without prominent nucleoli. So this is kind of difficult. So we send out this case as negative. But because now we have a positive specimen, so I would order the MOC31 for the prior specimen. And if we see now the specimen, the cell block for the prior specimen, I think this is positive. Yeah, I think this is likely positive, but it's just very difficult to see through on the original preparation. Yeah, so we would do a MOC 31 on this one. And please, I think this is Yowei. Please retrieve the requisition sheets. I want to check what's happening originally. Now, so going back, I think the first specimen should be possibly, we signed it out as negatives. So we need to double confirm that if anything's wrong. So let's move to the fine needle aspiration. This is a parotid aspiration. This is liquid-based preparation. So we see a larger chunk of cells with this very tight cluster. And when we go to higher power, the cell does have this oval shape, fusiform morphology, along with some extracellular, like chondromyxoid type of matrix material. So these looks like myepithelial cells embedded in like a matrix. So this looks like polymorphic adenoma. So whenever we encounter polymorphic adenoma, we usually would like to see what's the morphology on loose stent. So in loose stent, you show typical like these magenta color matrix material with a fibrillary edges, and the matrix intermix with the myepithelial cell like homogeneously. So this is very typical for polymorphic adenoma. And just like what I mentioned before, whenever we see a polymorphic adenoma, we will need to check if there is any cells with cytologic atypia, suggest that they might be a carcinoma X polymorphic adenoma. In this specimen, we do not see any, so this is benign. So we send it out as a benign polymorphic adenoma. We have three very interesting pap smear today. The first specimen is coming from a 63-year-old female. So she was noted with a pelvic tumor at the other hospital, so came to our hospital for consultation. So on low power, it looks just like a usual atrophic pap smear, a little bit more dirtier. Not very obvious is there any blood or any like endometrial debris, but just inflammatory cells. So at the edges of this specimen, we start to see individual cell in this very tight cluster, and the cell do show nuclear atypia. So I think the degree of atypia is already exceeding the usual AGC atypical glandular cells. So I think this is favored neoplasm. So along the direction, you start to see a little bit more. So again, this is a tight cluster, but it looks like it doesn't have any accompany like matrix debris, endometrial debris like material. So here, I think if you take a look at the cell, first of all, it is big. The nucleus is big. The chromatin is very irregular, and it is hyperchromatic. Comparing to the adjacent, this should be the usual like endocervical cell. This is usual type of chromatia, and this is hyperchromatia. And you see hyperchromatia polymorphism. So I think it's already exceeding the atypical glandular cell. We can call these favored neoplasm. The cellularity, the atypical cell is not plenty. They were just very scattered along this direction and not accompanied with any extracellular material. So in this situation, it's a little bit difficult to determine where is this coming from. It doesn't look like it is direct sampling from the cervix It could be coming from endometrium, but if it is not a type 1 tumor, endometrial type, it can show these like scattered highly atypical cells in the smear, or it could coming from the extrauterine origins. A little bit difficult to tell, and we do not see like a very obvious blood, like a bloody smear in these preparations. So a little bit difficult. But however, the patient already known to have a pelvic mass, so they need to investigate what would be the cause. So we signed it out as AGC, favor neoplasm, but it's indeed difficult to determine what's the origin of these atypical cells. So the next specimen is kind of easy. So on low power, you already can appreciate that there were no normal like squamous component, and we see only these debris-like material along with some old blood. And when we go to higher power, we see very tight glandular structure. The cells are big with vesicular chromatin, prominent nucleolus. So these looks like adenocarcinoma. And it is everywhere. Everywhere means that it is invasive. So we already see highly atypical tumor cells, and it's everywhere. It's invasive, and in the background it does show like a tumor dissesis pattern. So which means that this is a direct sample. So the lesion is in the cervix. That's why you can see it's everywhere. Okay, so this is compatible with tumor in the cervix, and then we go ahead to like a screen around, and it is also interesting that what is this? These are psammoma bodies, right? So psammoma bodies do not occur in the usual HPV positive adenocarcinoma. It is more common that you can see in serous carcinoma, particularly coming from the ovary. So this is a psammoma body. So when you see something like these very high-grade tumor cells without any mucin, and this psammoma body, you will think about, okay, this is not a usual cervical cancer. This can be coming from other places. And when we check the history, the patient got the past history of cervical adenocarcinoma, HPV negative, and which was a clear cell carcinoma. So occasionally, clear cell carcinoma can have very prominent psammomatous calcification. So this is compatible with a recurrence of disease. So these very high-grade tumor cells is unusual for HPV, and so the history confirmed that this is non-HPV associated cervical adenocarcinoma. Finally, this is even more interesting. 59-year-old female. So again, in the background, you start to see these atrophy type of patterns. So you see more cohesive sheets of these intermediate cells with higher NC ratio and with metaplastic morphology. In the background, you also see a lot of benign cervical glandular cells. So everything looks quite normal. So then we go around and we see a dot. So we start to see scatter like a typical cell cluster. The feature looks glandular. It is a little bit difficult to determine if these are repair or if this is not. it does show a little bit cytoplasmic process, but it is not as obvious as that we usually see for the repair, that the cytoplasm is usually more rigid and usually more dense, and the process is usually more obvious. And then you start to see that the cell does has prominent nucleolus. Prominent nucleolus also occur in a repair cell, so it doesn't against, it is a repair. So I think these cluster is kind of difficult. You want to debating that if I want to see these just repair cells, and we call it negative, or we should call these AGC. Okay, so basically the differential for these cluster is negative versus AGC, and you do see they are glandular, like a rosette forming pattern, and the cell does show some nuclear polymorphism, but nuclear polymorphism is also very common in repair. So we go along with this direction, and the first thing that you can notice that the endocervical cell looks really, really normal. It does not show any reactive change. And in the background, there's a lot of inflammatory cells. And you start to see these out of nowhere. So again, looks very similar. However, I would argue that it doesn't look much like repair because the cytoplasm is too fluffy. It's not very dense. It looks like a glandular cells with high-grade atypia. So this pattern is unusual, right? Because in the background, we do not see anything. In the adjacent, endocervical cells, we do not see any a reactive type of change. And then we start to see something like this. So this is what we call an alien pattern, that it is out of nowhere. And when we see something like this, we should think about the possibility of extrauterine origin. So here, again, we start to see a little bit more, and this is high NC ratio is very a typical arrangement. This actually looks like adenocarcinoma. This one is even more obvious. So if you see something like this, in other places, you would call this adenocarcinoma. So this is a very typical extrauterine adenocarcinoma pattern. So when you see something like this, you just check the history. So without any surprise, the patient had a prior history of primary lung adenocarcinoma. So this is compatible with metastatic lung adenocarcinoma. So we can do a cell transfer because you see the distribution means that there's a lesion, and we sample the lesion and smears along the direction, so they are scattered like adenocarcinoma cell just along this direction, and we can do a cell transfer half of these specimen, put it on the other slice, and do a TTF1 to confirm that it is coming from the lung. But the morphology, this is metastatic lung adenocarcinoma. Okay? So we can do a cell transfer, and this can use for this year for the annual annual meeting for our society for the presentation. Okay, thank you everyone.
Thank you.然后想请问一下，就是这前面这个 cervix，就是如果没有它。